I'm Dr. Khaled, Professor of Plastic and Maxillofacial Surgery, Ain Shams University, Egypt. Today we'll discuss the fingertip anatomy, evaluation, and treatment of injuries. It's a very important topic for plastic and hand surgeons. This is photo for Faculty of Medicine, Ain Shams University, and this is the university itself with its old buildings. The university dates to 1952 and the buildings even to 1901 or 1902. This lecture is intended for junior staff mainly. It will discuss the anatomy of the fingertip, how to evaluate the injuries, the options, and how to understand the limitations. It's very important, the limitation of every technique. Why the fingertip is very important. First of all, what is the fingertip? Let's discuss what the fingertip. Fingertip is the portion of the digit just distal to the insertion of the flexor and extensor tendons. I mean by this the nail bed and its nail plate, the perinechium, hyponychium, the bulb of the finger, the phalangeal fractures or the phalanx. All this part is considered fingertip. When you get essay question in the exam, you must mention and enumerate all these topics, starting from the nail plate, nail bed, the hyponychium, the perinechium, the distal phalanx, the bulb, distal phalangeal fractures, special types of tendon avulsions. We are coming to this later on. Why the fingertip is important? Why the fingertip is important? It's very important in fine pinch. You cannot pinch without your fingertip. Even if you have from the middle phalanx, it will not give the sensation, especially the tactile sensation, which is tactile sensation, grip stability, the object manipulation, how to manipulate things with very fine movements, and definitely the aesthetic appearance. Tactile sensation is for something like cloth, or what we call the between sensation, or stereognosis. Things like this are found only in the fingertip, is done only by the fingertip. This is a diagram for the fingertip. As we talked earlier, it's the nail plate. From the dorsum, it's the epinecium, nail plate, hyponychium on the nail bed, the phalanx, phalangeal bone, the bulb. Okay. What is the importance of the volar pulp? The volar pulp acts as fine absorption and fine tactile discrimination. Okay. Characteristics. It's fibrofatty tissues with numerous interconnecting septa, has very rich vascularity to support its structure and give blood supply. Just a minute, please. Okay, the pulp is approximately 50% of fingertip volume. The fingertip itself has specific nerve structures or nerve endings that aids in its functions, like Merkel's discs, which is located in superficial derms. They usually detect points and shapes and textures. Also the Messner's corpuscles, which are called tactile corpuscles. Also They are sensitive to low frequency vibration and skin motions. The Pacini corpuscles, detect deep pressure and high frequency vibrations also. The Ruffini corpuscles or bulbous corpuscles, they provide feedback about finger position and grasp. Okay, so let's move to the nail unit. The nail unit is composed of the nail plate, which is a hard structure supporting the phalanx itself, the nail bed, which is underneath the nail plate. It is divided into germinal matrix and sterile matrix. The germinal matrix is the matrix or the tissue that produces the nail plate, and the sterile matrix, it is distal to the germinal matrix and provides adherence to the nail plate. You will find the germinal matrix, it is like lunula, or what it's next slide here. It is the lunula, it is the whitish structure or whitish semicircle structure at the base of the nail plate. It is the germinal matrix. Following this, the hyponychium. The hyponychium is the junction between the nail plate and the bulb. It is not the tissue under the plate. It is just the tissue at the free edge of the nail plate, below the free edge of the nail plate. It is the junction between it and the bulb. The paronychium is the lateral nail folds that it makes like folds over the plate. The plate digs inside it and provides more stability for the nail. The eponychium is the proximal nail fold covering the matrix and the proximal part of the nail plate, and it protects the germinal matrix. When we get to the skeletal anatomy of the distal phalanx, it is formed of three parts. The tuft. The tuft is the broad thing that it is the end of the tuft of the phalanx. It's broad thing that lies just beneath to the nail bed and is very adherent to it. Okay, then the shaft, which provides structural support, and the base. The base carries the insertion of what? Yes, volarly flexor digitorum profundus and dorsally the terminal extensor tendon. Okay. Just a minute. Okay, the area, these are the base or the basis of the distal phalanx. It articulates with the proximal phalanx, okay, through the distal interpharyngeal joint. The vascular anatomy, it's important. Why it's important? You should keep in mind the vascular anatomy when you design your flaps, okay? So, the digital arteries, we know we have two digital arteries for every finger, two volar digital arteries for every finger, and sometimes dorsal bundle. The dorsal bundle is consistent in the thumb, index, may be found in the middle, and less in the ring and little fingers. These bundles form arcades. The arcades supply mainly, definitely the bulb of the finger is supplied mainly by the volar arteries. The arcade or the arch formed by the volar arteries. It supplies the bulb, the nail bed, and the skin. It's very rich in vascularity. Okay, as we talked earlier about the neural end plates, we have two digital nerves that form multiple terminal branches. These terminal branches decussate with each other, and it's very important to know that the 2-point discrimination in the fingertip is 2 millimeter, and it is the smallest area in the body and the most sensitive. As all we know that the nerves, the fingertip itself carries or takes innervation from the median and ulnar nerves volarly, and from the dorsal, from the radial arteries. And this is a finger. But the fingertip is mainly from the volar nerves, the median and ulnar. Okay. Also the innervation we talked earlier about. The digital nerves trifurcates make 3 branches, and each branch goes volar and dorsal and makes same arcades, then supply the distal end organs like Pacini, Messner's corpuscles, Merkel's corpuscles. Okay, as we talked earlier about the biomechanical, and the fingertip contributes to the precision pinch, which is the thumb index. We called it tip to tip pinch. The power grip when we are holding something powerfully. The sensory feedback. Many sensations are carried, like tactile sensation or touch sensations, like vibration sensations, like hot or cold sensation, like temperature. Um, Also, the tactile or the stereognosis, which is the in between, we call it in between sense. Also, the manipulation of structures. Okay, owing to this severely complicated anatomy in the fingertip, it's specifically mentioned in Quran, وَإِنَّ قَادِرُونَ عَلَىٰ أَن نُسَوِّيَ بَنَانَهُ. It's in English, after death we can even rebuild his fingertip. Okay, let's go to our main topic, which is evaluation. Evaluation, we should start with history. History, patient's age, gender, definitely occupation, and we will know later that occupation may finalize our decision when the patient is going early or must go early to his job. We cannot do um, big or complicated reconstruction, as this may lead to longer time away from work, and uh, sometimes manual workers depend on their daily income. Hand dominance, definitely. The occupation also, some very fine, like surgeons, like artists, like pianists. All these occupation needs very important and very complicated reconstruction with sensate flaps. Also, the mechanism of injury, and we will later discuss many mechanisms of injury. Any comorbidities like diabetes and Raynaud's phenomena or Raynaud's disease, tobacco use, as these things may impair our distal blood supply and limit reconstruction option. Even if you need to preserve the length, you may not go through these complicated options due to its general condition or comorbidities. Then we go to complete evaluation of the neurovascular status, tendon system. Definitely we must get radiographs, and we will talk later about the views. How mechanism of injury, it's a different mechanism, like crushing injury. We all saw children going after each other, and then suddenly one impacts his fingers between the door and the wall and gets crushed finger injury. Also, it is common in manual workers working with hammers and revolving machines. This is crush injury. Sharp amputations, mainly in both butchers or people who work with very sharp instruments. Avulsion injury. avulsion injury mainly in rotating devices. Degloving. Degloving means the tissues are avulsed from its place and then it is attached, but its blood supply may be um, still there. But the difference between avulsion and degloving: avulsion is the tissues are avulsed and taken from its place and they are no longer attached to the body. But degloving, the tissues are avulsed and they stay in its place. Even sometimes we call there's anatomical degloving, which is degloving of the tissues or avulsion of tissues, and then it is in its place, but all attachments are cut except one or two parts in the skin, but deeper structures are totally avulsed. And the physiological degloving, you look to the skin, you find it everything is normal, but underlying beneath, the blood vessels are crushed or avulsed. Okay, animal bites. Animal bites are very common, especially in population who breed cats. Okay, the clinical evaluation, like we said, we need to know the mechanism of injury, time of injury, mechanism of injury, time of injury, and others like dominance, occupation, as we said. Where the injury occurred is very important. Sometimes it occurs in soil places or places with animal feces. These injuries are really important and significant and may cause distal or may cause putrefaction, and these patients should receive tetanus toxoid or tetanus um, prophylaxis according to their previous prophylaxis history. Examination. First, by inspection, we look to the tissues. We see which tissue is lost, whether the nail bed or the finger pulp or the tip. We assess in centimeters the width, length, and the depth. And if there is any exposed structures like bones, tendons, or nail bed, if the nail plate is avulsed. And also if there is remaining tissues, its viability. This is an example of fingertip injury. It is from the pulp or the volar side of the fingertip. This one is nail plate avulsion with partial laceration of the nail bed. This is partial amputation of fingertip with exposed bones and lacerated wounds around. The nail assessment. First, we assess the nail plate. Is it still adherent to its place or not? The nail bed, whether it is lacerated or not, and the matrix. If there is closed or crushing injury with no injuries, with no cut wounds, but you find something like this bluish discoloration of the nail plate, this is what we call subangual hematoma. It is bleeding occurred from the underneath of the nail plate, which is a nail bed, and it signifies that if it is large, more than 50%, so most probably there is nail bed injury. Nail avulsion. Nail avulsion means the nail itself is avulsed from its place. And also we look for nail bed laceration. When you look to this patient, he has subangual hematoma. It's less than 50% and it is proximal. This patient has subangual hematoma with more than 50%, and this needs operative management, especially if he came earlier and it's tense. We will discuss later on this. Okay, this young This patient have nail plate avulsion with lacerations of the nail plate or the nail bed, laceration of the skin exposed of the distal phalanx, or it's avulsed, the nail plate is avulsed and exposure of the distal phalanx. There are three different things also we should or we must see. The bone assessment. We should palpate the distal phalanx for instability, tenderness, or shortening. We should examine the neurovascular examination as sensation and vascularity by capillary filling, and the tendon examination, where is the reflection or no flexion, extension or no extension. Okay. Next, and it is mandatory to do plain X-ray. Sometimes you have fracture in the distal phalanx and you just don't know, and you take it light. The patient comes after that by hook nail deformity or angulated distal phalanx. The two must views are the AP or the posterior PA and lateral, dead lateral. The finger itself without other fingers, it should be filmed from the lateral side itself. The oblique, it's optional. Okay, this is to assess the tuft fracture, the phalangeal fracture or base fractures. Sometimes you see avulsion of the flexor tendon or the extensor tendon was part of the bone, and this will be discussed also later. Nail bed injuries are summarized in subangular hematoma. It means that there is blood underneath the plate, sometimes which, if it is large, it signifies that there is nail bed injury. So what is the problem in nail bed injury? If there is nail bed injury, the preceding, the coming after nail plate will be distorted and may not be adherent, and it is aesthetically and functionally not good for the patient. Okay, so nail bed lacerations, it's written already. Nail avulsion, it may be partial or complete, and we will discuss also later. Germinal matrix injuries, sterile matrix injuries, and nail blood loss or avulsion, complete avulsions. The management of the nail plate. Just remember, the fingertip is not only the nail plate or the nail bed. It is all the structures that we are talking about. Okay? The subangular hematoma, if less than 50% conservative, if more than 50%, and painful, we need to make terrifying. What is terrifying? We make a hole in the nail plate. Hole in the nail plate. The hole is large enough to evacuate the blood underneath, and this is done actually early. When you see a patient after 5 or 6 days and the condition is stable, don't do evacuation. It's already the blood just spread underneath the nail plate, and no use to do terrifying. It's done early. When suspected nail bed injury as severe crushing injury or large hematoma, there is tension, we just remove the nail plate. Yes, we remove the nail plate carefully. We go with a mosquito with its curve following the nail bed and spread it. Definitely, I'm talking about patient under general anesthesia, better with tourniquet. And there is a general and very, very important thing that we should consider. In fingers, we put tourniquet with an instrument like mosquito or something like this. Why? You will never discharge the patient with a mosquito in its finger, but you will sometimes with blood, and sometimes in the emergency room, you will discharge the patient with the tourniquet, and the patient may not feel the ischemic pain due to the local anesthesia you gave. So very important just to put the elastic and stretch, then apply a clamp or mosquito, just to remember. It's very important, and we saw patients coming, unfortunately, after days with parts of the finger gangrenous due to the tourniquet effect of the elastic you put. Okay, the nail bed injuries are repaired with very fine absorbable sutures, 6-0 or 7-0 under magnification. As we talked earlier, if there is like bumping or irregularity in the, especially the germinal matrix, it will cause abnormal plate or abnormal adherence of the plate, which is cosmetically disfiguring, and also functionally this patient may not practice his work due to this non-adherent nail. It always just gets hit and painful. In case of nail avulsion injuries are identified. We wash the nail bed and see if there is underlying injuries, nail bed. Then we reattach the nail plate. We don't throw the nail plate. We reattach the nail plate by non-absorbable sutures, by 3 or 4 sutures, to keep it as a splint. It's very important not to throw the nail plate. Keep the nail plate in its place and put, even if it is totally avulsed, just bring it back and put it as a splint, and to cover the nail bed and prevent its desiccation and later on shortening of the nail plate. It's very important. So if you didn't find the nail plate, what would we do? Very, very simply, you just cut silastic or something from what we call like saline or solution bottles. We cut it as the nail and suture it in the same way the nail plate was, and keep this like for 1 or 2 weeks or 1 month till the new plate starts to grow and push this. Sometimes you have nail bed avulsion and you don't find it. We need to reconstruct this. We harvest from the toes nail bed grafts, either split or full thickness. Usually we take it split thickness to avoid disturbance of the toe, especially in females. We take split nail bed grafts and put it even on bare bone, and the bare bone in the distal phalanx is one of the cortical bones in the body that accepts, even it's bare, that accepts putting small sized grafts like nail bed grafts, and the take it's very good, and even it's taken and it's dealt with as our regular split thickness skin graft with tie over and moist dressings. Okay, so this is how we define or how we treat the nail bed injuries. Then we jump into soft tissue injuries or avulsion injuries that involve different or composite structures of the nail. First, we have many classifications like Allen classifications, Tamite classifications. These classifications aim to describe the deformity. First, this Allen classification, it's type 1, which involves pulp only. Type 2, it involves pulp and nail. I'm sorry, this is wrong. Type 2 is not involving the distal phalanx. Type 2 is just here with the bone not exposed. Type 3 is a bone exposed and most of the nail bed gone. Type 4, it's injury even just distal to the insertion of the tendons. Just to show more this these classifications, we have